We have started another chapter regarding the arterial surgery. We have been discussing about the arterial stenosis and the arterial occlusion in the previous lecture. Today, we'll be talking more specifically about the gangrene. Particularly, if you could appreciate the diagram, there are two pictures which are being shown on your screen. One is the dry gangrene and the other is a wet gangrene. But first of all, obviously, you guys should know what a gangrene is. So it is actually the macroscopic destruction of the tissue because of the compromised blood supply. So if we particularly talk about the causes for the gangrene, most commonly, peripheral vascular disease is the causative agent behind the development of the gangrene. But if we talk about other systemic diseases, particularly about the diabetes, in the diabetes, there are three important factors. One is ischemia, other is a sensorimotor neuropathy. They lead to the development of the gangrene. So particularly, how are you going to define the gangrene? That is the macroscopic damage of the tissue because of the compromised blood supply or because of the damage to the vasculature particularly. So there are two types of the gangrene. One is the dry gangrene and other is the wet gangrene. So dry gangrene is basically, just owing to the deficiency of the blood supply. There's hypoxia to the tissues, and because of the hypoxia and ischemia, there is damage to the tissues, and because of the release of different cytokines and interleukins, with the passage of time, progressively they developed edema, and because of the more compromised blood supply and more compromised vasculature, they develop a full-blown necrosis. So without superaided infections, the development of ischemia and hypoxia ultimately lead to the dry gangrene. On the other hand, you can see here is gangrene. So in case of wet gangrene, there are superaided infections as well, and because of the superaided infections and because of the pussy discharge and edema fluid and everything, that accounts for the development of the wet gangrene. So whenever you are suspecting, whenever a patient comes to you with the development of the gangrenous foot, you should always think about the peripheral vascular diseases, because most of the time, there can be the widespread phenomena which is called atherosclerosis. So we know that in case of the atherosclerosis, the age, the hypertension, the risk factors, specifically smoking, alcohol, sedentary lifestyle, they all actually, predispose the patient to the development of the atherosclerosis. And because of the atherosclerosis, there is a deposition of the lipids and the cholesterol within the walls of the vessel, and they lead to the luminal obstruction. And after a full-blown atheroma is developed, or the atheromatous plaque is developed, there is aggregation of the platelets. And when the platelets, adhere to the surface of the atheroma, that atheroma is particularly converted into a thrombus. So because of that thrombus, because it is obstructing the vessel and the lumen of the vessel is obstructed, and the diameter is lessened. So because of that, there's compromised blood supply. So there are two important things you need to remember, that in case of the acute, ischemia, that's more life-threatening, and there are more chances of development of the gangrene within 6 hours, right? But in case of the chronic limb ischemia, when the occlusion is not to the critical level, so because of that, there is development of the collateral vasculature. So we all know that whenever the collateral vasculatures are developed, the blood still goes on, and the blood supply to the specific organ in the tissue is not compromised to that extent. So because of that, the patient usually do not develop the gangrene, and it's a gradual, slowly progressive process, and the presentation is obviously not acute. So always keep in mind a patient coming to you with a gangrene and is giving you a particular history that I have developed. First of all, I had got edema, there was redness, and ultimately it's turning black in color. So it is the indication that there's hypoxia and ischemia to the tissues, and because of that ischemia, there's necrosis of the tissues, and because of that, inflammatory mediators and the cytokines, they release, the macrophages pull and the neutrophils goes out there, and they convert the dry gangrene into the wet gangrene. So actually, almost all the time, the gangrene actually starts distally and extends to the proximal limbs. So actually, usually the foot fingers, the big toe, they are the first one to be affected by the gangrene, and ultimately, obviously, the whole of the foot. And the gangrene actually travels distally to proximally. So in case of the dry gangrene, most of the time the gangrene is just limited to most distal portion. But in case of the wet gangrene, because of the superaided infection, there's more propensity to travel to the more proximal part of the limb of the body. So that's how this is somehow very much important. The process of converting the dry gangrene into the wet gangrene, that is kind of a poor prognostic factor, and ultimately the patient ends up with the amputation. So this is somehow very, very much important. If you're suspecting gangrene and the patient is coming to you within 6 hours and particular symptoms, we'll be discussing about the symptoms later on in the lecture. But if a patient is coming to you with this presentation, we'll think about the arterial occlusion, and obviously you will try to relieve the obstruction as soon as possible, because if the obstruction is not relieved, then that dry gangrene would be converted into a wet gangrene. There's another important thing which is very much significant. That is the line of the demarcation. So in case of the compromised vasculature and the compromised blood supply, and the patient is developing a peripheral vascular disease, so there's a clear line of demarcation between the avascularized tissue and the vascularized tissue. So if you could see here in this diagram, it is actually, sorry about that. So if you could see, there's a clear line of demarcation between the healthy and a non-healthy tissue, like the ischemic one and the healthy tissue. And obviously, this actually travels from distal to the proximal limb. So most commonly, obviously, the effect would be on digits, particularly the big toes and the fingers of the foot, and proximally traveling distally to proximal, and then involving the metatarsal and, moving upward. The involvement of the bone is, that's a very, very poor prognosis, and ultimately the patient ends up with amputation. This is somehow very much important to decide and take a decision about the amputation of the limb. Either it's a single, because already if a gangrene has developed, so there's tissue necrosis, and it is particularly irreversible. So the decision is somehow very much important. The reason being because if you do not end the process, it will keep on traveling proximally, and it will end up in a sepsis. And obviously, when a full-blown septicemia develops, there's a multi-organ failure. The patient goes in DIC, which is disseminated intravascular coagulopathy, and morbidity then turns mortality into mortality, right? So that's how it's somehow very much important, and you should remember the time period is 6 hours, and obviously you have to relieve the obstruction within 6 hours. After that, the patient will the ischemia will develop, and ultimately it will end up in the amputation. So there are specific types of the gangrene. Particularly, I told you most of the time, in 80% of the cases, the gangrene develops because of the thrombi and in the background of the atherosclerotic plaque. So if there's already a throma, and because of the there's a platelet aggregation to that atheroma, and ultimately that atheroma is converted into a thrombus. So because of that thrombus, there's occlusion of the vessel, and obviously there is a compromised blood supply, and the tissue start developing necrosis. Other type of the gangrene, there's a diabetic gangrene. Bed sores are one of the type, which are particularly the pressure sores and the frost bites. So if we talk about the diabetes, three things are very much important. There's a macrovascular complications and the microvascular complication. And in case of the diabetes, most of the time there's a glove and stocking pattern. And obviously it involves the proximal, it involves the distal vasculature, first of all, and then it travels proximally. So the thing about the diabetes is like three phenomena. This is somehow very, very much important. One is the ischemia, and second is peripheral neuropathy. So actually it causes the demyelination of the axons because of the high blood sugar levels. These high blood sugar levels, they affect the degeneration. They start the process of the axonal degeneration, and because of that, plus there's a small vessels which are supplying the nerves as well. So because of the diabetes, those small vessels which are supplying the nerves, they got damaged, and because of that ischemia to that, there's a sensorimotor neuropathy. So sensory is the first, and later on it develops a motor neuropathy, is the glove and the stocking pattern. The third thing, which is most important in the diabetes, is because of the high blood sugar level, there's a state of the immunosuppression. So three things: one is ischemia, number two is a sensorimotor neuropathy because of the axonal demyelination and the degeneration, plus because of the compromised blood supply to the nerves, the small arteries which are supplying the nerves, and because of that there's a sensorimotor neuropathy. And the third thing was the high sugar levels, which are actually which are causing the immunosuppression. So in the diabetes, these things are very much important. So the phenomena for the development of the gangrene is we divide into different stages. So in the first, there's only redness and the pain, and ultimately it develops a pulselessness, paraesthesias, and because of that there is redness or edema, and ultimately if the vascular supply is not restored, so what happens is the ultimately necrosis develop. The other thing, and because of the necrosis, there are full-blown cellulitis and diabetic foot develops, and ultimately it ends up in amputation. Another thing which is somehow very much important is the bed sores. So mostly they are the pressure sores, and they develop most of the time in those patients who are immobilized, and those patients which have other comorbidities like hypertensive, there's some kind of problem with the they have some kind of ischemic heart disease, they're bedridden, and or they have undergone a long surgery like the orthopedic surgery. So the patient, because of the pressure, the vasculature is again affected, and the bed sores develop. So it's also kind of the gangrene, and we divide these pressure sores and the bed sores into 4 stages: grade 1, 2, 3, and 4. In grade 1, there's only redness and a rash. And most of the time, the rash is a non-blanchable rash. When you try to compress that most of the time if there's a rash and you try to compress that, it goes away, and it refills when you lift up your thumb. There's a blanchable rash. But in case of the bath sores, the first grade 1 stage is basically the rash and a non-blanchable rash. And the second stage, there is, the dermis and the epidermis goes away. The third stage is when the necrosis, extends to the deeper tissues involving the muscles. And the fourth stage, the necrosis extends to the bone, and ultimately there is involvement of the bone as well. So actually, in case of the bad sores, again, you have to restore the blood supply. The pressure changes. Put the patient for the air mattress, and frequent postural changes, debridement if necessary, and a good dressing like the deodorant dressing. They are particularly important in case of the bed sores. The third most important type is a frostbite, and most of the time it's usually in the extremes of the temperature, and particularly those patients or the people who are working in high altitudes or who are living in snow for a very long time. They develop the frostbite because of the vasoconstriction. To accommodate the temperature, the atmospheric temperature. There's a vasoconstriction of the arteries, the small digital arteries. So what happens is, like, because of the vasoconstriction, there is, a compromised blood supply, and ultimately, because of the compromised blood supply, there's tissue necrosis, and because of the release of the cytokines and the inflammatory mediators, the process of the full-blown inflammation develops, the necrosis develops, and ultimately they develop a full-blown gangrene. So in case of the frostbite, what is important is like to mediate the temperature, to put the patient to put the limb, particularly if we talk about the foot, in a warm, lukewarm water. And you also give some kind of analgesics, good analgesics to the patient. You also give good vasodilators, particularly the calcium channel blockers. So they're very much important, and they've got a good effect in case of the frostbite because they're the vasodilators. And most of the time this develop because of the vasoconstriction. So whenever you give the patient the calcium channel blockers, they dilate the vasculature, and because of the dilatation, blood supply is again the compromised blood supply goes away, and because of the blood supply is restored actually. So because of that, there's good oxygenation to the tissue and regeneration, and that's how the things goes on. So keep in mind, the most important cause for the gangrene is peripheral vascular disease, and behind that there's a full-blown phenomena of atherosclerosis. And because of the atherosclerosis and aggregation of the platelets, the thrombi develop, and because of the thrombi, there is compromise in the blood supply, and ultimately the necrosis and the gangrene develop. And in case of the other special varieties of the gangrene, diabetes is somehow very much important, and the mechanism behind all this is ischemia, sensorimotor neuropathy, and the third thing is immunosuppression because of the high blood sugar levels. The other, we talk about the bed sores, and we talk about the frostbite as well. Now, this is somehow very much important topic to be discussed, which is about the acute arterial occlusion. So again, most of the time, if we talk about two phenomena which are very important. One is the formation of the thrombi, and second one is the emboli. So in case of the acute arterial occlusion, the background behind all this is obviously the formation of the atherosclerotic plaque, and ultimately these atherosclerotic plaques, they actually develop the thrombi. So you can see here, you can see particularly these are the RBCs, and ultimately there are different kinds of the atheromas, right? And because of that, there's aggregation of the platelets. So actually what happens is the high cholesterol level, there's a lipid deposition, and these platelets, they get aggregated to, these platelets get aggregated to the atherosclerotic plaque. So you can see here, so you can say like these are particularly at the the periphery or to the wall side. This is the lumen and this is the wall of the artery. So actually these atheromatous plaques, they start to develop in the intimal layer. So sometimes these are the platelets and RBCs which are actually flowing with the blood within the vessel lumen. So actually the platelets, they get adhered to this atheromas, and ultimately they form the thrombi, as you can see in the picture. So these thrombi block the vessel, and because of that there's compromise in the blood vasculature, and ultimately the patient develops ischemia, necrosis, hypoxia, and ultimately it ends up in occlusion and the gangrene. Now the thing is this, that if there's a 50% of the occlusion, there's a term which is particularly called a critical stenosis. So, if there is a 50% occlusion, there are development of the collateral channels, and, the process goes on, and vasculature, because of the development of the collateral vasculature, there is no compromise in the blood supply. But if there's a critical stenosis, and particularly like 90% or the 70%, if there's 70 to 90% of the occlusion, the patient becomes symptomatic, and the process of ischemia and the gangrene, that starts away. So one pathogenesis behind all this is atheromatous plaque. The other, for the development of the acute arterial occlusion, is the emboli, and most of the time these emboli comes from the heart, right? Like if the patient has got the atrial fibrillation, or if the patient has in the left ventricle, there is a mural thrombi in the left ventricle, or they're kind of the infective endocarditis, or there's a valve agitation. So what happens is like they broke away from that, and they ultimately go somewhere else, and they block the blood supply. So this is the phenomena of the emboli. Like they're the torn off pieces from the thrombi, and they migrate from their primary location, and they ultimately go somewhere else and they cause the occlusion. They can be anywhere in the brain, in the eyes, causing the occlusion of the central retinal artery. There can be in the mesenteric artery, which is ultimately causing the gut ischemia, which is the acute mesenteric ischemia, and ultimately the gangrene develops, and it ends up with a gut resection. So that's how it's somehow very, very much important. Like if you could appreciate in the diagram that that was a primary thrombus, and those thrombi which are vulnerable, or they are larger in size, or there is left atrial fibrillation, or there is a valve agitation in case of the infective endocarditis, or there are left ventricular mural thrombi. So sometimes they break away from their point of origin or their point of formation, and they go somewhere else, and they cause the obstruction, right? So it was primarily here, and this emboli get dislodged or torn off from its primary site, and it ultimately stuck in here in the lumen of the artery, and there's more of the platelet aggregation, and ultimately that particular blood supply is compromised because of the occlusion. So always keep in mind, if you are suspecting acute arterial occlusion, whether in the limbs, in the brain, in eyes, in the central abdomen, like in the superior inferior mesenteric artery, always suspect that there is somehow either, the protein deficiency, like the protein S, the factor deficiency, antithrombin C deficiency, or there is, most of the time, these emboli, they originate from the heart. So there might be, always go for the echo of the patient. There may be valve agitation, there can be infective endocarditis, there can be ventricular thrombi, or there can be left ventricular fibrillation. That's how somehow it's very much important. So if you could see here in the diagram, this is actually the aorta, and this is particularly the abdominal aorta. So actually the abdominal aorta divides into common iliac. So these are the right and the left common iliac, and most of the time these emboli, they get dislodged from their primary location, and they get stuck in the bifurcation of the abdominal aorta. So if it's a kind of the, in case of the emboli, this is somehow the presentation is more acute. Why? Because, there's no development of the collateral vasculature. But if there is a thrombosis, then obviously this is a slow progressive phenomena and the background of the atherosclerosis. So what happens is, you can see here in the diagram that this is the site of the obstruction, but there are the collateral vessels. So the the circulation or the blood supply is not affected in case of the thrombosis. But in case of the emboli, because it's an acute emergency and the collateral vessels are already not there, and because of that there is an acute obstruction, and these occlusion ultimately make the patient symptomatic. So if we talk about the embolic occlusion manifestations, they can be in the limbs, there can be in the brain, there can be in the eyes, or there can be in the abdomen. So if it's in the arm and leg, ultimately it will cause gangrene. If it's in the brain, somewhere in the middle cerebral artery, so most probably the patient will develop stroke, right? And if it's in the the central retinal artery, there would be acute blindness, and the patient will give you the history that sudden loss of the vision, right? And if it's involving the abdomen, particularly, the mesenteric arteries. So what happens is the vasculature of the blood supply of the gut is, compromised, and the patient develops severe abdominal pain, and it's somehow vomiting and the signs of the intestinal obstruction as well, because ultimately the patient is developing gangrene. So you can see here in the diagram that this is the, I was talking about the line of the demarcation. So this is the line of the demarcation. And most of the time in arms and the legs, if we talk about the embolic occlusion, so it's more distal as compared to the proximal vasculature. So you can see here in the diagram, this is the line of the demarcation, and the patient has already developed a full-blown gangrene. And if it's in here, it's involving the most distally, like the fingers, because why it's affecting the distal vasculature, because these digits, if we particularly talk about the fingers and the hands, or the toes and the fingers and the foot, their vasculature is like, they have a very limited blood supply in the form of the digital arteries. So they are the first to be affected. So in case of the embolic occlusion, there would be a gangrene in the distal vasculature and the distal limbs as well. So there's embolus, which is obstructing the mesenteric artery. The patient will complain of the severe abdominal pain. So overall, there are 5 P's which are very much important if you're suspecting acute arterial occlusion or the acute peripheral vascular disease, right? So pain is the most important, then paralysis. It's a sensory paralysis and a motor paralysis as well. First of all, the sensory function will go away, and I'll say later on the motor function will go away. So the pain, paralysis, pallor because no blood supply, pulselessness because no blood supply, and obviously the paraesthesia because obviously the small vasculature which is supplying the nerves, they're also affected. So because of that neuropathy, there is paraesthesia and a numbness. So pain, pulselessness, paraesthesias, pallor, and obviously the paralysis. These are the important things you need to ask in your history, and you need to examine the patient as well. If we talk about the embolic occlusion manifestation, amaurosis v gas, this is somehow, the embolus get dislodged from the parent side, maybe somewhere in the left atrium, maybe it's a valve agitation, or it's somewhere in the it's a kind of the mural thrombi in the left ventricle. So what happens is like it get dislodged from that particular side, and it obstruct the central retinal artery, right? These are the short ciliary arteries. There's the anterior ciliary artery, and this is obviously another anterior ciliary artery, and this is the optic nerve which is coming. So because the blood supply of the eye that's mainly coming from the retinal artery. So a retinal artery internal is internal carotid, a branch of the internal carotid. So somehow if the thrombus get dislodged in embolized form, the emboli gets stuck in the close in the central retinal artery, and all of a sudden the patient will develop sudden loss of the vision. This is called amaurosis v gax, and obviously the phenomena behind, the culprit behind all this is the embolic. So the embolic occlusion. So the embolic occlusion in the eye, the manifestation would be acute loss of vision or the acute blindness. Okay, in case of the limb, if the embolic occlusion develops, the patient will complain about the acute limb ischemia, and the presentation would be the same: pain, pallor, paraesthesias, pulselessness, and paralysis. So initially the sensory factor is affected, and then the motor part is affected. So you can see it's a normal, healthy looking foot, but on the right there is a dusky discoloration. That means obviously it's not the full blown gangrene, but it's a kind of the limb ischemia. So the process is still there, and if you do not restore the circulation, you do not put the patient on antiplatelets, anticoagulant, or you thrombolize the patient, obviously it will end up in a gangrene. So the dusky discoloration, the pain, the pulselessness, the paraesthesia, the paralysis, numbness, these are all the signs of acute limb ischemia. So if we particularly talk about the clinical features again, they're almost all the same, and you have to remember the 5 Ps. First, obviously, the first symptom would be pain. Other would be pallor because of the, pallor, because the kind of the discoloration because of the compromised blood supply. There would be paralysis later on. Firstly, the sensory part of the nerve would be affected, and the motor nerves would be affected, and ultimately the patient will develop paralysis, loss of pulsation, and paraesthesias, or kind of the numbness. Again, the sensory part, it would be affected, and there would be cold limb because of the compromised or the absent blood supply. So if the patient is giving you all these, the history of all these things, features, and also you'll think about the acute limb ischemia, and you'll think about the embolic occlusion somewhere, and you'll will investigate a case. But first of all, you will immediately treat the patient, because if the patient is reported to you within 6 hours, and then obviously you need to put the patient on antithrombotic therapy or the thrombolysis, and the first thing you have to give is obviously the heparin, and the heparin usually you give is 5,000 units tight dose, and then you put the patient on a low molecular with heparin. The other procedure, or the kind of the intervention you can do, is embolectomy. And obviously, if the patient has developed acute limb ischemia, then you go from the proximal vasculature and you give an incision at the inguinal region in exposing the femoral artery, and you put the probe inside, and you try to do the embolectomy, and also you do the thrombolysis. So Thrombolysis can be done by two methods. One is like the intervention, obviously because the catheter, and then the catheter with the balloon, and you leave the catheter or stent within the vessel, and so that the lumen of the vessel should be patent, or the balloon dilatation, of course. So first thing you're going to give the patient in case of the acute limb ischemia is 5,000 units of the heparin dose, and then you have to put the patient on the loading dose, and then obviously you have to put the patient on maintenance dose. The other thing is embolectomy, and the other thing is thrombolysis. You go through the femoral artery proximally, and you make the distal the connection, and then you do the embolectomy by a special instrument, which is the probe, particularly for that. And how you do this thrombolysis, you insert the catheter again into the femoral artery. You go from proximal to distal. You do the stenting, or you give the tissue plasminogen activator. This is somehow the work of the intervention cardiologist. They usually do these things. So what you do is the process for how to do the embolectomy is like, this is the femoral artery, and we know that the position of the femoral artery is like in the femoral triangle, which is located in the inguinal region. So you give a kind of the incision here, you insert the catheter, and through this the probe you perform the embolectomy, as you can see. And obviously there's a balloon which is attached to that catheter, and you inflate the balloon, you leave the balloon out there, and you just remove the catheter then, right? So this is how you do the embolectomy. And the other process I've already explained, thrombolysis. How you do this again, you're going to go with a catheter, you can expose the femoral artery, you're going to go deep inside through the femoral artery by the help of the catheter, and then by the help of that catheter, you push tissue plasminogen activator into that, and obviously the catheter is withdrawn then. This is how you do the thrombolysis. As you can see here in the picture, almost, as you can see, this is the the distal part or the distal vasculature is being compromised. You put the catheter, and then the vasculature or the blood supply is being restored. Okay, so we have discussed so far about the acute limb ischemia, the clinical signs, features, and what are you going to do? Put the patient on anticoagulant, antiplatelet therapy, give a loading dose of the heparin like the 5,000 cc, and then put the patient on maintenance dose. Else you can do is embolectomy or thrombolysis. An embolectomy, you just put the catheter through the femoral artery, then you inflate the balloon, you remove the embolus through the probe, you inflate the balloon and keep the balloon out there, and remove the catheter then. Right? This is embolectomy. And in thrombolysis, what you do is you again go inside to the femoral artery by the inguinal incision, and catheter is being inserted, and through the catheter you give the tissue plasminogen activator, which is a thrombolytic agent, and by the help of that, again, you take out the catheter again later on. That's how it is being treated. And again, you put the patient after the procedures, you still have to put the patient on antiplatelets and anticoagulants. There's another thing which is important, which is called the compartment syndrome. So in case of the compartment syndrome, actually, whenever there is edema, and because of that edema, if we talk about the limbs, particularly the arms, after the edema, what happens is like, the arm is divided into facial compartments, right? Anterofacial compartment, posterior compartment, and the lateral compartment. And every compartment has its own blood supply, has its own nerves, has its own muscles, and obviously those muscles, they have a particular function, like all the flexors of the anterior compartment of the arm, of the forearm, is meant for deflection. There's a flexion moment, right? And all the posterior compartment muscles of the posterior compartment, they are posteriorly, and they're the posterior facial compartment, and they're particularly responsible for the extension of the arm. So flexion is the anterior compartment, extension is the posterior compartment. So whenever there is edema, and because of that edema in the narrow space available in the facial compartment, the nerves out there, they are compressed, and the patient developed the compartment syndrome. As you can see, because of that, because of the pressure, the nerves are irritated, the nerves are compressed, and obviously the blood supply is also being compromised. So because of the blood supply, the patient developed the compartment syndrome. It's kind of excruciating pain and pulseless, paraesthesia, all those symptoms. It's a kind of the ischemia. So what you do in compartment syndrome is to do the immediate fasciotomy, in which you go through the medial compartment. You start giving the incision from the palmar crease and extend medially. That's how this is as you can see here in the diagram. This is the picture showing the fasciotomy in the leg, right? So how you do is like you go from the medial compartment and you start giving the incision, and you try to relieve and drain the edema fluid, so that obviously the facial space is available, and the compression of the nerve in the artery is being relieved. As you can see, this is a kind of incision. You go medially, you relieve the kind of obstruction, you relieve the tendons, and obviously you try to expand the facial space, so at least the edema fluid is being drained and the compression effect is being reduced. So that was a embolic occlusion, which is involving the arms and the legs, or particularly the limbs. There's another embolic occlusion, which is the acute mesenteric ischemia, and it's a kind of the emergency, and the patient will present to you with severe abdominal pain, right? We know that the proximal gut, the mid gut, and obviously the hind gut or the distal gut. So actually the proximal gut is supplied by the celiac artery or the celiac trunk, the midgut is supplied by the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. So if the embolus get dislodged somewhere from the heart and get dislodged and get stuck in the the superior mesenteric, inferior mesenteric, or the celiac, obviously the supply of the obviously the supply would be compromised, and the patient will develop gangrene. So you can see here in the diagram that this is superior mesenteric artery, and this is the different kind of branches which are supplying the part of the duodenum and obviously the jejunum, the small intestine. And if there is embolus right here, and one of the branches of the superior mesenteric involving the whole trunk of the superior mesenteric artery, there would be ischemia of the gut, and the patient will present to you with severe abdominal pain, and ultimately you have to do the exploration. Mostly you cannot diagnose the case of the acute mesenteric ischemia merely in the investigation. So you have to open the patient, you do the exploratory laparotomy, and obviously you then find out that there's a large gangrenous gut, and ultimately you resect the gangrenous portion and you do the anastomosis, the primary anastomosis. There are some kind of the other forms of the emboli, which are the infective emboli of bacteria. They're parasitic emboli, there's a fat embolism, there's a venous embolism, and obviously there's air embolism. So this infective emboli of the bacteria is most commonly in the infective endocarditis. These valve agitations, they are usually they are developed on the valves, and ultimately some of the emboli, they get dislodged from here and they stuck somewhere else, and they cause acute arterial occlusion. There's some kind of the parasitic emboli as well. Fat embolism is very, very much common in the large bone fractures or after a major trauma. So what happens is, like, whenever there's a trauma to the large bones, long bones particularly, they cause fat embolism, and ultimately it goes to it's stuck in the pulmonary artery, and the patient develop the acute respiratory failure. And if it's get lost somewhere in the renal artery, the patient will develop acute renal failure. And there are another type of the emboli as well, which are the venous emboli, and most of the time the venous emboli, because the IVC is, the superior vena cava and the inferior vena cava. They goes to the right atrium of the heart. Into the right atrium, they goes to the right ventricle. So most of the time, these venous emboli, they get dislodged and they get stuck in the pulmonary artery, and the patient develops the pulmonary embolism. And obviously, those DVT, deep vein thrombosis, is likely and more prone to cause the PE, which is the pulmonary embolism, and is a quite increasing in the patient who undergo recent surgery, like the orthopedic surgery, and they're immobilized, and they develop already the deep vein thrombosis, and obviously one of the thrombi, they get dislodged, and it goes to the heart, it goes to the pulmonary artery, it blocks the pulmonary artery, and ultimately the patient develops the respiratory failure, and obviously the heart failure, left ventricular heart failure, and most commonly the right ventricular heart failure as well. There's another entity, which is the air embolism. And in case of the air embolism, if you're trying to venipuncture as some kind of the process, so what happens is you inject the air bubble, or you are doing somewhere surgery in the head and neck, or there's a trauma to the head and neck, because the internal jugular vein, the interior jugular, external jugular veins, these are located, they're most important veins which are located in the neck. So if there's a trauma to the neck, or there is head and neck surgery, there's likelihood of developing the air embolism, and obviously the manifestation would be the same. So the treatment option for this, in case of it's acute arterial occlusion, mesenteric, limb ischemia, or air embolism, you have to put the patient on therapeutic embolization. And how you do it, you put the patient on anticoagulants, antiplatelets. If it's possible, the embolectomy, wherever, like in case of the in the distal vasculature, particularly limbs. But if it's involving the abdomen and the intestine, then obviously what's the option? The option is accelerated laparotomy and resect that portion of the gut which has already developed the gangrene, and then you have to do the primary anastomosis. So this is also the therapeutic embolization, and again we do it in the same way by injecting the catheter and the balloon dilatation. So that was about the acute arterial ischemia. We have discussed about the gangrene in today's lecture. We have discussed about the acute mesenteric ischemia and acute limb ischemia. So thank you for watching sqadia.com.